Subcommittee. Thank you for inviting me here to testify today, and I applaud the subcommittee's effort to shine a light on the danger posed to seniors by the Independent Payment Advisory Board, better known as IPAB. I have practiced medicine for the past 31 years, not been in Congress. This is only my second term, and I'm an OBGYN doctor, and I found out delivering your own voters worked out pretty well for me. So, but I firmly in my core believe that healthcare decisions should be made between physicians, the patients, and their families, not by a board appointed by the president or anybody else, Republican or Democrat. Created as part of the Accountable Care Act that went into effect last year, the IPAB is charged with developing proposals to reduce the per capita rate of growth in Medicare spending. Certainly something has got to be done to ensure that this important program remains available not only for current retirees, but for the next generation as well. The Medicare trustees recently projected that the Medicare Trust Fund will go bankrupt in 2024, and it's been stated the Congressional Budget Office says that the fund will exhaust even sooner in 2020. We already know what President Obama's plan to save Medicare is the $500 billion in cuts to the program and the IPAB. The cuts speak for themselves, but the American people deserve to hear the truth about the IPAB as little more than a roadmap to potentially rationing care. Now, some say that the Accountable Care Act expressly prohibits rationing, raising revenues or beneficiary premiums, increasing cost sharing, or other restrictions on benefits. This is highly misleading, as nothing in law prohibits cutting payments to physicians. Already, Medicare pays physicians between 85 and 90 cents on the actual cost of the care, which has made it more difficult for beneficiaries to access the needed care. If reimbursements continue to fall even further, it could very well become economically impossible for physicians to see Medicare patients. With millions of baby boomers becoming eligible for Medicare, IPAB cuts couldn't come at a worse time. The IPAB could adversely impact the quality of patient care. For example, look no further than Britain's National Institute for Health and Clinical Excellence, or NICE. Decisions are based on cost, not quality or outcomes for an individual patient. Decisions regarding patient care shouldn't be made by a panel of 15 unelected bureaucrats who haven't examined the specifics of an individual's unique case. Medicine is not a one-size-fits-all discipline. What is effective for treating one patient may be harmful for another. By centralizing medical care decision-making, the IPAB would put a Washington bureaucrat squarely between patients and the care recommended by their doctor. In addition to degrading access to and quality of care, IPAB has two significant structural problems. It's both unaccountable and unworkable. The board is empowered to make recommendations regarding Medicare without any input from Congress. Don't just take my word for it. The former OMB director, Peter Orszag, called the IPAB the single biggest yielding of power to an independent entity since the creation of the Federal Reserve. Even after the IPAB makes its recommendations, the hands of the Congress are still somewhat tied. The proposal will be considered under fast-track procedures, and without 3/5 vote of the Senate, Congress can only modify the types of cuts, not the size. And if Congress fails to act on the board's recommendations, they automatically go into effect. This isn't government by the people. It's instead government by the bureaucrats. Questions have also been raised regarding IPAB's ability to function as it's designed. In reference to IPAB, the CMS Chief Actuary, Richard Foster, wrote in the April 2010 memo that limiting the cost growth per beneficiary to a level below medical price inflation alone would represent an exceedingly difficult challenge. The CBO, on the other hand, projects no savings resulting from IPAB over the next 10 years. In both cases, these expert analysis suggests that IPAB will not yield the results promised by its proponents. Further, the legislators who created the IPAB made it clear that they want this board to impact more than just Medicare. The Accountable Care Act requires the IPAB to make recommendations about how to restrain private sector health care cost growth as well. While these recommendations do not automatically go into effect, they will no doubt serve to encourage private insurance companies to cut provider payments. Ultimately, cuts to provider insurance payments will result in even less access for Medicare beneficiaries because most providers shift costs onto private insurance to make up for Medicare losses. So everyone loses under this scenario. While it seems that there is little that our two parties can agree on in the current environment, both sides have acknowledged that the IPAB is a terrible idea. That's why my bill to repeal IPAB, the Medical Care Decisions Accountability Act, has more than 160-plus bipartisan co-sponsors, with all but one physician in the U.S. Congress has signed on. The American Medical Association has endorsed my legislation, as did a broad coalition of more than 270 healthcare organizations. Even former Democratic leader Dick Gephardt called the IPAB's repeal. Mr. Chairman, it's time that we begin the fact-based conversation about reforming Medicare without the demagoguery that has marked recent months. I can't think of a better place to start than a bipartisan effort to repeal IPAB. Let me finish with a couple of things. Ask yourself two things or two problems. Does this bill increase access and quality of care for seniors? And number two, how much oversight and power has Congress given up? And let me just give you a brief example. If you're a family practitioner and you're seeing Medicare patients and you want to continue to do that, and let's say your practice grosses $300,000 this year, which is probably what a family practice would do. About $150,000, that 50%, if you run a very efficient practice, is overhead. If you cut, the current SGR growth cuts are recommended to be about 30% at the end of this year. That family practitioner who's making a very comfortable living at $150,000, his or her costs stay at $150,000, but their income will be cut to $50,000. And how does that increase access? If this IPAB basically can do that, how does that help our seniors? I very much appreciate the bipartisan support for this, and I thank you for having me here today.
Chair thanks the gentleman, and now recognizes Congresswoman Schwartz for 5 minutes for her opening statement.
Thank you, Chairman Pitts and Ranking Member Pallone, Mr. Waxman, and members of the committee for the opportunity to testify this morning. First, let me say I have been and continue to be a very strong supporter of the Affordable Care Act because it will extend access to affordable, meaningful health coverage to all Americans, strengthen Medicare, and contain costs for American families, businesses, and government. The potential for savings is significant. The Centers for Medicare and Medicaid Services, CMS, Office of Actuary, estimates that over the course of the first 10 years, the Affordable Care Act will save Medicare more than $400 billion by attacking fraud and abuse, reducing overpayments to insurance companies, reducing medical errors and unnecessary duplication of services, increasing access to cost-effective primary care services, and improving care coordination across healthcare settings, and transitioning to payment systems that reward value. CBO estimates that the law will reduce the deficit by more than $1 trillion over the next 20 years. And that's just the beginning. Healthcare reform has the potential to fundamentally transform the healthcare delivery and payment systems by creating a variety of models for improved delivery of care by incentivizing high quality, greater efficiency, and better outcomes. Successful implementation will ensure that seniors get the right care at the right time at a lower cost to taxpayers. My decision to support repeal of the Independent Payment Advisory Board reflects my confidence in the many cost containment measures in the law. Despite Republican claims, IPAB is not a